Hello, my name is Harutyun. I'm a pediatric radiologist at Children's National Medical Center. And in the next 20 minutes, we will be talking about ultrasound in pediatric surgical emergencies. This presentation was made with Tara Tielma, one of our sonographers. So objectives of the presentation are to talk about sonographic appearance of selected pediatric surgical emergencies and discussing techniques and search patterns, along with use common pitfalls and mimics. Dividing some of the pediatric emergencies in age group, we may get some form of distribution like that. Unfortunately, given constraints of time, I will only talk about pyloric stenosis, malrotation, appendicitis, and intussusception. So talking about pyloric stenosis, it's a relatively common disease. There is some familial predisposition as well. Males are more commonly affected than females, and the usual age distribution is from 2 weeks to 5 or 6 months, with the most common age group anywhere from 2 to 4 months. And locating the pylorus is important, and it's the biggest challenge in defining the pylorus. I do recommend sonographers to start palpating the abdomen first. If they feel a focal thickening or olive-like thickening in the upper abdomen, that's the area where the imaging should be concentrated, and that's the area that we should image. The linear transducer with a relatively higher frequency is the one suggested to perform the examination. 9 to 12 megahertz is a reasonable frequency to get started. A lower frequency transducer may not be as helpful in depicting the pylorus. Locating the pylorus is important on ultrasound here, where you need to see certain structures next to the pylorus. That's the gallbladder, liver, pancreatic cat, SMA, SMV. There's the antral portion of the stomach, and the duodenum is here. This is an example of an abnormal pylorus where the muscle is thickened. This is long axis and short axis use of the same patient. There's an example of a normal pylorus where we see the muscularis externa, submucosa, and the pyloric lumen. Pancreatic head is seen here on this long axis view, and liver is also visualized. There's a cine clip of the same long axis view that shows that the pylorus is open and the stomach content is freely extending into the duodenum through the open pyloric channel. Here is a zonal anatomy of the pylorus with a very high frequency transducer with a high resolution. Multiple layers can be seen. There's an echogenic mucosal layer inside, followed by muscularis mucosa, which is a hypoechoic layer. It's a very thin muscle layer. It is not what is being affected with hypertrophic pyloric stenosis. Then there's a submucosal layer, and there is a muscularis externa layer, which is also hypoechoic. And this is the area that's being thickened with the hypertrophic pyloric stenosis. And serosa is echogenic. Here is an example of a normal and abnormal pylorus next to each other. And all the layers of normal pylorus are seen on the left. With abnormal pylorus, all the layers are also seen, but muscularis externa is thickened. Here, that thin layer after that is muscularis mucosa, and that's not being involved with the disease. An example of short axis of an abnormal pylorus with thickening of muscularis externa. Diagnostic criteria on ultrasound are the measurement of pyloric muscle of less than 3 millimeters for a normal pyloric muscle, and the pyloric channel should be less than 15 millimeters. Here is an example where the muscularis externa, here, this hypoechoic area, is not thickened, followed by mucosa, and muscularis mucosa here with the lumen. And then a cine clip, you can see the content of the stomach freely flowing through the pylorus. Here are diagnostic criteria of the abnormal pyloric enlargement, more than 3 millimeters thickening of the pyloric channel, pyloric muscle here, completely closed pyloric channel, and we can also see the measurement here is 4 millimeters, and the length of the pyloric channel is more than 1.5 centimeters. On the cine clip, the pyloric channel is closed and does not open here, the antral portion of the stomach pylorus here. So some of the pitfalls that we commonly encounter is incorrect measurement of the pyloric wall, where the mucosa and submucosa, the entire wall is included in the measurement. That's incorrect. What should be included is only the muscularis externa, that hypoechoic layer. And here's the correct measurement of the pyloric wall here, which measures 1.5 millimeters within normal range. And here's an example of an incorrect measurement on the left, where the entire wall is measured, including submucosa and muscularis mucosa, and measurement is 3 millimeters. With a better technique, the muscularis externa is only seen, and that should be the only one measured, and that measures less than 2 millimeters. Same example, except for the short axis view, where the measurement is incorrect on the left and correct on the right. Some of the pitfalls that we encounter also is difficulties visualizing the pylorus that can be due to bowel overlying the pyloric region or gastric overdistension. An example of the bowel overlying is here, where compression on the upper abdomen and a better sonographic window through the liver help to eliminate the problem. Gastric overdistension is a common issue, especially when in patients who do have the positive pylorus, for pyloric stenosis. The reason for that, their stomach is commonly overdistended. They are crying. There is a lot of air and a lot of gas within the stomach, and the pylorus may be hiding under the stomach. What helps to troubleshoot in cases like that is that I place patients on the right lateral decubitus position, so right side down, and that helps to bring all the liquid close to the pylorus, helping me to visualize through the liquid. On occasions, I have to give patients milk or fluid or water to achieve the same thing, where the liquid falls near the pylorus, and I can image through that. On several occasions, I had to place a nasogastric tube to suck out the content out of the stomach, so to be able to visualize the pylorus after that. Another pitfall that we have encountered on several occasions is there has been a confusion of gastroesophageal junction with the pylorus. In a unexperienced hands, the gastroesophageal junction looks sonographically very close to how pylorus looks. The way to differentiate is the location. It's important to remember, if in your field of view you have air from lungs or heart, then you're too way high up there for pylorus, and you're probably looking at gastroesophageal junction. To image the pylorus, I think that's another example of the gastroesophageal junction here, where it does look like a pylorus, but it's in a wrong location. Here you can see the diaphragm, you can see the liver here. The way to image here, the pylorus is at a much lower level, where the gallbladder and pancreatic heads are seen. If you're seeing heart or lung in the field of view of what you think is the pylorus, it's probably not a pylorus. It's probably gastroesophageal junction. Pyloruspasm is another mimic of is another pitfall, or potentially mimic hypertrophic pyloric stenosis. The way to differentiate is with pyloruspasm. If you rescan within several minutes, or if you look at it in real life, like on the cine, the pyloric channels gradually opens and closes. Remember that pyloruspasm or borderline appearance of the pylorus may indicate that this is a very early changes of pyloric stenosis, especially if the patient's symptoms persist. So if you see on ultrasound a picture where the pyloric wall appears prominent, what you think may be a pylorospasm, it's important to talk to the surgeon and talk to the parents that if the symptoms do not go away within a week or two, then, or especially if they get worse, then a repeat ultrasound may be necessary at that point. As an example, this pylorus to me looks borderline, even though I don't think this is a time for this patient to get surgery. It looks more like a pylorospasm on this opening and closing views, but I won't be surprised if this particular patient comes back in several weeks with a full-blown pyloric stenosis, or they may improve. So not a time for surgery yet, but may be under risk of developing one. So some take-home points is the muscularis externa is what you need to measure, and not the entire pyloric wall. And the measurements are less than 3 millimeters for wall thickness, and the length is less than 15 millimeters, and no peristalsis of the pylorus. All right, shifting gears here, let's talk about malrotation and volvulus. It's a surgical emergency, as you know, and it's an example of a normal rotation of the bowel on the left, intraoperative picture, and drawing of a malrotation. Malrotation, volvulus, and bowel ischemia, they commonly go together, but not necessarily. Patients can have a malrotated bowel without volvulus, and there are patients who can have volvulus without active bowel ischemia. There are also extremely rare reports of volvulus without malrotation. Gold standard for imaging of malrotation is fluoroscopy. Ultrasound can be very helpful as well, especially if a Whirlpool sign is present, and we'll see that in a second. It's a diagnostic for volvulus. Swirling or Whirlpool sign is the in appropriate clinical settings, in my opinion, you should send patient to the operating room. You do not need to confirm it on fluoroscopy. Abnormal orientation of SMV and SMA may suggest presence of malrotation, but they're not specific. Here is a normal orientation of SMV and SMA, where SMV is on the right of SMA. If there is a reversed orientation, that's an abnormal orientation. And if they're in line to each other, that's also an abnormal orientation, and that can be indicative of underlying malrotation, even though it's not specific. I think what is specific is this pattern on a cynic clip where you see the swirling or Whirlpool sign in the upper abdomen immediately under the pancreas. So if the patient has appropriate clinical presentation with this Whirlpool sign, meaning the patient has an abdominal pain, it's in the correct age group, or other clinical sign of malrotation and volvulus, this type of Whirlpool sign is enough to send patient to operating room immediately. If you choose to confirm it with an upper GI, that's probably a picture you will get where there is a volvulus with twisting. Here on the left pictures, there is an abnormal orientation of SMA and SMV, and bowel walls more distally are thickened, which is suggestive of ischemia in this region. So appendicitis is another, probably most common surgical emergency that we encounter in our emergency department. Our first line imaging or modality for ultrasound, for appendicitis is ultrasound. Here are the criteria that we use. It's the appendix should be more than 6 millimeters or less than 6 millimeters in size. When it's more, it's positive for appendicitis. Needs to be hypervascular, non-compressible. There may be an appendicolite or fluid around the appendix, and mesenteric echogenicity is present. Here's an example of appendix with an appendicolite. Here's an example of a normal appendix, a blind ending structure here, filled with air and content. And here's an example of an early appendicitis, mild dilatation with fluid, increased vascularity, small amount of fluid adjacent to it. Another sign that we use is the compressibility of the appendix. Here, this particular appendix is not significantly compressible. And also, there is a lot of inflammatory changes surrounding the appendix, looking at this increased epigenicity of mesentery here. The measurement criteria are important, where you measure from wall to wall, compared to the pyloric stenosis that we just discussed. Measurement for appendix abnormal, in the cases of abnormal appendicitis, should include serosa measurement. Sometimes it's difficult to find the appendix. I mean, it's commonly difficult to find the appendix on ultrasound. So it's important to look in different areas. It can be in the right lower quadrant, in periumbilical region, interretrocecal region. Graded compressions are important to try to find the appendix. Usually it's advisable to find the point of maximal pain and push in this area as deep as we can to try to find the appendix. The secondary signs of appendicitis are free fluid, abscess formation, and mesenteric edema with appendicolate formation. In this particular case, we do see appendicolate freely floating in mesentery. Here, another example of appendicitis with dilated appendix, large appendicolate present, hyperemia, and inflammatory changes surrounding the appendix. Here's an example of perforated appendicitis where abscess is seen posterior to the urinary bladder here, correlating images on the CT scan showing the same large abscess. So it's important also to touch upon reporting of appendix ultrasound that we do in our hospital. I think it can range from normal appendix, and we do see the tip, which reassures everyone this is not a case of appendicitis. Sometimes we do see the appendix, most of it, but we do not see the tip, in which case it's pretty reassuring. But the fact that we do not see the tip, we cannot exclude isolated tip appendicitis, so we do report that as well. In cases when we do not see appendix, but no secondary signs, it's reassuring, but not 100% accurate or specific for absence of appendicitis. The patient may still have appendicitis, just simply not seen or deferred. In cases when we do see appendix, but there are inflammatory changes in the right lower quadrant that suggests appendicitis, but the inflammation can be from something else. And also, in my reporting, when I see the appendix that it's inflamed, I do try to determine if it's ruptured, if there is an appendicolate, if there's an abscess or phlegmon next to it to help the surgeon. In selected cases, we do see the appendix. It's just borderline. It measures maybe 6-7 millimeters. We can't determine if it's inflamed or not. It's kind of equivocal for appendicitis. In cases like that, I choose to we can either get a CAT scan or reassess with ultrasound within 12 to 24 hours. And then some cases, there's just simply too limited examination due to bowel gas that prevents us from seeing anything in this region. Intussusception is the last thing I wanted to talk about, and ultrasound is highly sensitive and specific in diagnosis of intussusception. There are two signs. It's a target sign like that, and pseudokidney or kidney sign, sandwich sign. Usually occurs from 6 to 36 months of age, usually idiopathic. It's in the right colon. It's ileocolic intussusception that we're worried about. The classic triads is colicky pain, bloody stool, and palpable mass. We do attempt reduction in radiology department with air enema. We perform it under fluoroscopy. We do not use sedation or anesthesia for cases like that. Here is another example of intussusception. And it's important not to confuse ileocolic intussusception with small bowel to small bowel intussusception. Small bowel to small bowel intussusceptions are most likely benign and transient, and they have much smaller diameter than ileocolic intussusception. And that's all I had for you today, and thank you for your attention.